Very much, and good evening, everybody. A very warm welcome to our 2021 Cambridge University Hospitals annual public meeting. My name is Mike Moore, and I have the great privilege and honour and responsibility of being the chair of Cambridge University Hospitals. And I'm delighted to say that I'm accompanied here tonight by members of the board, both executive and non-executive, and by Julia Loudon, who is the lead governor for the trust. So a very warm welcome, and forgive the sunshine is blowing, it is in my eye at the side here. Apologies, hopefully the sun will go down before we conclude. So good evening. We will this evening be focusing on what's been happening across the hospitals over the past year, and we will also look forward to and be looking at the challenges that we're currently facing and the period ahead. Just a very procedural point, we would normally at the annual meeting be presenting the annual report and accounts for 2021. Those who are familiar with kind of corporate governance will know that that's a feature of annual meetings. I'm afraid this time we're not able to do that simply for a timetabling reason. Our accounts have been audited. That is all complete as a process, and there are no worries in that process. But within the general national picture, we have to have, those have to be laid in Parliament before we can publish them. And they've not yet been laid in Parliament. This is a national picture. It's not a specific picture to ourselves. So we decided that rather than hold this meeting back for another month or so before the accounts are laid in Parliament, we would do the meeting tonight, and we will be having the opportunity, hopefully they will have been laid in Parliament by then, to present the accounts to the next meeting of the Council of Governors, which will be in December, the 15th of December. And we'll be happy to take any questions that members of the public have about the accounts at that point. So my apologies that we're not taking the accounts to you, although it's rare to have to give apologies for not taking accounts, but we will be bringing them to the December Council of Governors. But to hasten, no worries about them. This is just a timetabling issue within the parliamentary timetable. We'll be hearing very shortly from Julia Loudon, who is our lead governor, and from Roland, who is our chief executive. And then there will be an opportunity to take questions from any of you, either questions you've already got by your considerations about the hospital, or questions that are prompted by what Julia or Roland say. Just a bit of housekeeping about giving questions. You will find the ability to do that on Facebook, if that's the way you've come in and are watching tonight. Alternatively, if you are looking at this on Zoom, then there will be the chat or the Q&A functions, hopefully in your Zoom functionality. And there will also, if you're on Zoom, you're able to click the virtual hand. And between us all, hopefully, we will detect that you have raised a question, and hopefully between us all, we will be able to pick that up and bring you into the conversation. So hopefully that all works for you. And of course, one of the impacts of COVID is that we're all, or many of us, are increasingly more familiar with this way of having a conversation. As ever, as a trust board, there are some changes. We've had we've had elections this year that we'd held back from the previous year for the Council of Governors. So my thanks to all departed governors and my continued welcome to new governors. We will be having some changes in the composition of the board, in that we are losing a couple of non-executive directors as their terms expire in the next few months. And we have brought in some new non-executive directors. So that, again, is not unusual. It is just by the function of the nature of terms that people have. I'm also very pleased and happy to report that we've made we've had changes in our executive functions. Some people, for example, have been asked nationally to take on roles temporarily, which we've been very glad as a hospital to say yes to, because we recognise our contribution to national picture. But I'm very good to see that we have huge strength in depth and have brought in some excellent candidates within the executive, some of whom are here tonight. And that just goes to show something which is very important to this hospital, which is the strength and depth of our executive leadership, of which I'm hugely appreciative. So, and I want also, before handing over to her in a second or two, to give a particular thank you to Julia, who is our lead governor, for whom I think I'm right in saying this is your last formal role or session tonight as lead governor after many years, because again, your term comes to an end and you'll be replaced by Neil, who's taking your role on Thursday, or Friday rather. But Julia, a really huge thank you from us all for an excellent job that you've done in both challenging but supporting us through the very difficult journeys we've had over the years as a hospital. And I personally much appreciate that. So before I hand over to Julia and Roland as Chief Executive, let me just give a few very brief personal reflections, but I'll keep them brief. First of all, of course, all of us in on this call have been affected in ways I guess none of us ever anticipated or imagined possible by the events of the year that we're talking about tonight. It's had a great impact on us all, on the way we conducted our lives, on people's livelihoods, and in some cases, of course, on people's futures. I can only think of children and college students whose futures have been affected by their experiences over the last year. And of course, at its core, it's been a profound physical and mental health challenge for many. Second, I just want to say that I am deeply, deeply appreciative of the steps that our staff within the hospital have taken, always with great professionalism, with great compassion, with great concern about the professional standards of care that they're able to provide, and sometimes at great personal cost, the sacrifices and the anxieties that many of our staff have had to bear over the last year and continue to do today is something that is uppermost on my mind personally, and I know that of the board. I'm also, thirdly, appreciative of the support that you as members of the public and the local community have given us. And I hope that you know that your appreciation of us is deeply acknowledged by people inside the hospital. People have been deeply touched and felt deeply supported by what you, the members of the public and the local community, have done for people in the most challenging of circumstances. And I hope that you as the community and as members of the public and as members will know that that is deeply, deeply acknowledged by the hospital. At the same time as dealing with the most profound health and professional set of challenges as a hospital, we've also had to make sure that we were also keeping an eye to the future in order to make sure that we are securing our sustained future as a hospital in order to carry on providing services to you, our patient and community public. So work has gone on despite the intensity and at times overwhelming nature of COVID, on the development of the Children's Hospital, on the development of plans for the Cancer Hospital, and for the shape of any redevelopment of the core of the hospital as well. All of which has secured to some degree financial support from government, but which we continue to work to bolster and to fulfill. So we have been working hard on that. The other thing that we have continued to work hard on as a hospital is how we work with the totality of the health and care system. Many of you will know and will have seen what for us are distressing pictures of, for example, the pressures in A&E in the hospital. These are not things that we take lightly or regard as acceptable. We know that these are areas where patients' experience is not what we would want them to be. But we also know that we need to work with all of the system, primary care, community care, and other partners in order to try and create sustainable solutions to these very intractable and very challenging problems. And I'm sure we'll come back to that in some of the discussion. And finally, we've also worked very hard at the same time as COVID on trying to improve the way we, as part of a whole overall biomedical campus, operate. And we know again that we have continued challenges and a continued determination to improve the way the campus operates, both for those who visit it and also those who join it as our neighbours, because we know that that causes some problems and we want to be good neighbours. So without further ado, I'll hand over to Julia as lead governor. So over to you, Julia. Julia, I think you're on mute.
Thanks, Mike. Yes, this time last year, we were at the end of the first wave of COVID, and in my presentation to members at that time, we were at a point where we were starting to look to a time when the focus would be on recovering routine hospital services. But the second wave over winter was even more challenging, and during that period, governors were updated regularly on how the Trust was coping. The updates we received were things involving the real-time modelling of scenarios in terms of numbers of COVID patients requiring inpatient treatment and those very sick patients who needed intensive care. The implications of these numbers on the management of wards across the hospital and the need to redeploy staff from their home wards to help care for COVID patients, and how learnings from the first wave were being built into new revised treatment protocols. And as the number of COVID patients in the hospital reduced, we learned of the plans to reintroduce services and manage patient waiting lists while still maintaining a COVID-safe environment. I believe I speak for all governors when I say that we had, during that time, regular opportunities to discuss the ongoing and increasing impact of COVID on staff and services with Mike, Roland, and the non-executive directors, that we felt informed on how the Trust was managing the crisis, be this through the modelling work I've described. And the forward thinking on how to cohort wards, both to minimise risk of hospital-acquired COVID and best manage COVID and non-COVID patients. The continued support being provided to staff, the steps being taken to maximise diagnostics and treatment of non-COVID patients through partnership with independent hospitals in the area, and the plans to develop and bring services back to Addenbrooke's in a timely way. What we haven't been able to do over this period as governors during COVID is to be inside the hospitals, participating in PLACE. These are the patient-led assessments of the care environment, and 15 steps ward inspections. In normal years, we would observe patient facilities and how wards were working and have the opportunity to meet staff, patients and family members and hear their views. So we do look forward to being able to return to those activities. As Mike had mentioned, as a consequence of COVID, the governor elections in 2020 were postponed, and they were held again in May this year. So in July, we welcomed 12 new governors across patient, public, staff, and partnership constituencies. As yet, due to ongoing restrictions, we haven't all been able to meet face to face, but we're still doing our best via Zoom. From a governor point of view, I mean, the courage and commitment that staff have demonstrated after an additional year of pressure is nothing short of extraordinary. However, we also recognise that the relentless pressure of the pandemic continues to take a tremendous toll on both patient and staff, and is significantly impacting in many ways the efforts to re-establish efficient and effective treatment pathways for our patients. Moving on, at previous annual meetings, I've provided a perspective on the Trust's performance versus its targets and highlighted any areas of particular concern for governors. But over the last 18 months, many of the national performance targets have been impacted by COVID. So I'll just comment on two quality measures that have been a topic of many governor discussions, yet are still proving difficult to change. The National Staff Survey ran as normal during 2020, and given the other priorities, CUH recorded a good response rate to that survey. Over several years, the CUH ratings for domains relating to equality, bullying and harassment have been disappointing, and despite several initiatives designed to improve equality and help reduce the incidences of bullying and harassment, the Trust has been unable to make significant moves on these aspects. So as governors, we'll continue to seek assurance that appropriate steps are being taken to tackle issues of inequality, bullying and harassment. And we do know that this is one of the Trust's workforce priorities. Early discharges are a critical element of capacity planning and management of flow through the hospital, and governors have focused on this metric in previous years. So again, it's disappointing that there's still proving difficult to make sustained progress towards a target of 20% of patients being discharged before noon. However, over the last couple of years, a cycle of improvement initiatives have been implemented across a wide range of hospital services. And while some of these projects had to be put on hold during COVID so that staff could concentrate on delivering urgent care to patients in the hospital, the Quality Committee has continued to apply appropriate focus across all aspects of treatment quality and patient care. These projects are now restarting, and together with initiatives being developed in partnership with the Institute of Health Improvement, governors look forward to receiving updates and statistics on how these are making a difference, including to early discharges. So looking at some topics in which governors have maintained a special interest during the last year. While working remotely, governors have continued to participate across a range of trust committees, and we attend as observers the board assurance committees. These are chaired by the non-executive directors, they're attended by non-executive directors and management executives, and they scrutinise all aspects of performance, quality, workforce and education, and audit. Earlier this year, a new committee focusing on the major building projects was formed, and governors also now observe at that one. As a result, over this year, we've identified, maintained a special interest and sought assurance from the non-executives on a range of topics. And examples of these include some concerns we had this time last year regarding the time it was taking to confirm the funding and to build the Surge Centre, which was designed to provide urgently needed additional ward capacity. This facility was opened earlier this year. The service is available for the treatment and rehabilitation of patients suffering extended symptoms following COVID infection. The process by which patients whose treatment had been delayed as a result of COVID would be identified, contacted, and scheduled for treatment. The management of eating disorders, particularly early identification and continuity of care in adults, adolescent, and paediatric patients within the Trust and in collaboration with regional partners. And staff wellbeing and services, which were under significant stress during COVID and continue to be so. And through the Governor Strategy Group, we've been able to contribute thoughts and ideas to the Trust strategy, particularly in relation to building on the learnings from COVID. In the coming year, governors will focus across all aspects of the Trust priorities. And as part of this, we'll seek assurance that the learnings from COVID are both being built into everyday working practices and are being used to strengthen the Trust strategy going forward, such that future shocks of any sort can be withstood and managed. That hospital services, including emergency department attendances and waiting times, elective surgeries, diagnostics, and the backlog of waiting lists are addressed as efficiently and as effectively as is possible in this challenging environment. That the recruitment of and that staff recruitment, staffing of wards, equality, diversity and inclusion and staff support services are ongoing and urgent workforce priorities. We'll follow progress with the major building projects, including the additional capacity wards for Addenbrooke's, the new Cambridge Children's Hospital and the Cancer Research Hospital, ensuring design plans take account of input from staff, patients and the public. We've recently initiated a project with the Trust's communications team to refresh the membership engagement strategy. After such a difficult period, and with the changes coming to how healthcare is to be delivered across the region, it will be important for governors to engage with the members of the public to understand how we can best represent their needs and concerns. And as the Cambridgeshire and Peterborough integrated care system develops and becomes established, we'll work with governors from the other trusts involved in the ICS to agree how we can best provide a collective voice on behalf of our members. Clearly, the pressures that CUH, like all other trusts, have always faced on a daily basis, high emergency department attendances, long waiting lists and issues with hospital capacity and flow, have been exacerbated by COVID. Within this challenging environment, I'd like to reassure you that governors take their responsibilities very seriously, and we'll continue to do our best through discussions with the non-executive directors and others to ensure patients receive the treatment they need and that staff are supported in their efforts to deliver the care they provide. Finally, this is almost my last day as lead governor, as Mike said. I complete my term tomorrow after more than 5 years in the role. It has been a privilege to work with so many passionate and dedicated people across the Trust, to participate in a wide range of Trust initiatives and being involved with the hospitals during the challenge of COVID. I look forward to continuing as a patient governor for the rest of my third term. So on Friday, the 1st of October, I'll hand over to Neil Stutchbury, who will lead the governors for the next period. Neil is a passionate advocate of patient views, and I know he'll do an excellent job. Thank you.
Thanks very much, Julia, and again, our great thanks to you. Julia, I'll hand over to Roland and then we can come into collective conversation, but colleagues who are watching or members of the public who are watching, please, if you have any questions in regard to what Julia has said, put them in by the Facebook facility or on Zoom by raising your hand, chat or QA, and we'll pick those up when we have the collective conversation after Roland. So Roland, I'm going to hand over now to you. So here's Roland, the Chief Executive.
Lovely, thank you so much, Mike, and thank you, Julia. I mean, Mike and Julia, when we've spoken, there are so many things that we could cover today. And I think what we think is best is to really start by grounding what follows in the people and the partners we've worked with, and then move on to a bit of a reflection on what's gone well from the last year, what's been more challenging, and what we think about the lessons learned, and then come on to the future. So in terms of grounding us, CUH, Cambridge University Hospitals, Addenbrooke's and the Rosie is first and foremost about people and the partners we have the privilege to work alongside. And Mike and Julia, like you, I'd like to extend an enormous thank you and well done to our patients, our population, our communities, our staff, and the very wide range of partners we've worked alongside. Those partners include the University of Cambridge, CUH UK, industry, CUH UK led by Sharon Peacock, one of our non-executive directors, through to colleagues in the health and care system, in general practice, community services, social care, Health Watch. I could go on, Royal Papworth. And also other partners, our partners in Addenbrooke's Charitable Trust, who have reached out so effectively into our population to really listen to the support that was available. And in terms of the people you can see and the partners you can see on this page, in these small photographs, if you go up to the top line and just one from the right, you can see a nurse in personal protective equipment, PPE suit roster probably arranged by you in your role leading on PPE in the COVID pandemic. And that nurse is somebody called Jane Olds, who is one of the nursing leaders for our critical care unit. Staying with the people, if you come down to the left-hand side, far left-hand side, and it's the one picture up from the bottom, that's Charlotte Summers. So Charlotte's employed by both the University of Cambridge and Addenbrooke's, and she is a consultant who leads on critical care. If you were to go just to the bottom line, to the yellow picture where it says your support, you can just make out Gemma and Alex there from Addenbrooke's Charitable Trust, working so hard to get us the support that we needed during the pandemic. And if you go right to the middle of the picture, there's Ravi. Ravi works again in infectious diseases and microbiology between the hospital and the university and many other partners, really helping us get into the guts of tackling the COVID-19 virus. So those are the people that we're talking about who came together to tackle the last year. If we could go to the next page, that would be great. So Mike and Julia, on to, if you like, what's happened over the last year. Well, a huge amount. So you can see there on the left-hand side, we treated over 2,000 patients with COVID-19. We increased our critical care beds from 30 to 40 to over 100. And these critical care beds are what Ashley would call full fat critical care beds, really intensive care to support patients who were profoundly unwell, both with COVID-19, but also patients we were treating in terms of major trauma or transplantation or cancer. We operated under very strict COVID secure guidelines, and it's great to see, I think that's Doug there, the security guard, really helping make sure we were doing all we could to keep our patients and our staff safe, making sure that people were wearing masks, that we were maintaining social distancing. The work of people like Doug was absolutely central to making sure that this was a safe place to be. And then bottom right, the simple 3 words, redeployed many staff. It's hard to express the admiration I think that we all have for those colleagues working in nursing or physiotherapy who put themselves forward to be retrained by Lorraine's team, by David Werrick's team, to then be redeployed into different parts of the hospital, which I think for many colleagues was a very scary experience and something that they leant into with enormous courage. If we move to the next slide, Namu, many other things happened. So we supported over 200 research studies across the Cambridge Biomedical Campus and the Cambridge ecosystem, indeed the national research effort. And those are the sorts of studies that meant that we were able to ensure the very best possible cutting edge treatment for patients, not just here in Cambridge, but also across the Eastern region and indeed nationally. We opened additional capacity, and it's lovely to see Bethany Ricketts there. I think she's standing at the end, well, she must be standing at the entrance to T2, which is one of the first openings of the 120 beds that we've got on site. And then, as Ashley Shaw, as the medical director, will know, I'm sure Ashley can remember every moment of this, we implemented a COVID-19 testing and vaccination program with enormous support from David, your occupational health team. And Mike Keach, we managed to deliver the financial plan. And a big thank you to you and Adrian for all you've done there. And Mike, this point around 90% of pre-COVID theatre capacity is important. This is about what we were doing to make sure we were back as fast as possible to being able to provide care to people where COVID-19 was not the condition that we were worried about. If we move to the next slide. I think though, Mike, as you were alluding to, and Julia, we've also faced some really significant challenges. We've got a lot of things right. We've also got some things wrong, and we're going to very much take those things forward. So significant challenges for us are the pressure on our staff. I mean, before COVID-19, we were at about 4% vacancy in terms of staff, I think Shirley and David. We're now at sort of 8 or 9% and working very, very hard to bring that vacancy factor down. So we've got the people we need to be able to treat patients and to ease the pressure on our workforce. We're facing very high levels of emergency demand, people wanting to come to the emergency department. And at the same time, we're thinking very hard about how we can do all we can to treat people in outpatients and people who are waiting for surgery, be that complex surgery or less complex, low acuity surgery. And Adrian, I think what you and Sharon are doing in Performance Committee and Quality Committee is, I think, really helping us think through the balance we need to strike between, if you've lost 10% of your bed base, how do you strike the balance between caring for people coming in through the emergency department and people waiting for surgery? What are you doing in terms of the pressure on staff? What more could you do on infection control? Where are we really on innovation and improvement? And I suppose something that isn't here in terms of challenges is the profound difference of experience of colleagues from different backgrounds, different protected characteristics. That is something we're going to want to take forward in the workforce strategy that I'll touch on in a moment. And if we could move on, that would be lovely. Okay, so final piece on the last year. So as we all know, it's hugely important to learn from COVID-19. And Mike, you as chair said, I'd like us to commission a lessons learned review, not from somebody externally, but I'd just like us to really think internally, what have we picked up here? And we talked to staff, we talked to our partners, we talked to patients to see what lessons we could learn and what we could take forward. So here are the 5 themes that really came through for us. So clarity of purpose. The second bullet point there, power to the front line. So listening to the experts and putting them in control of the controls. Thirdly, using technology in everything from outpatients to how we were in effect testing the different variants of COVID-19 so we could work out how it was evolving. Working in partnership. We've talked about some of those partnerships already. I'm incredibly grateful to the Institute for Manufacturing from the University of Cambridge, who leapt into the hospital to help us plan how we would have enough oxygen across the trust to look after patients in the first wave. And then also the central theme, Mike and Julia, of putting staff and partners at the heart of all of our thinking. If we could move on. Thanks so much. So looking ahead, our strategy now has 3 components. So the first is around improving patient care. The second is around supporting our staff. And then the third is around building for the future. And then if we go to the next slide. So first of all, improving patient care. So really at the center of this piece is recognizing where we sit in terms of our physical capacity and how our workforce are feeling and how many members of staff we have. How can we look after patients locally, across the Eastern region, in some cases nationally, with the capacity that we've got? How can we innovate? How can we use what we've got to the very best of our ability? But we have some really exciting things that are happening. We have the 120 additional beds coming on site at the moment. It's great to see the first 20 of those open. And we have real innovation, things like artificial intelligence in radiotherapy. And I've talked about outpatients already. But I think another piece that will be central to our journey, and Mike, you alluded to this in our work in the integrated care system, will be much more purposeful engagement with tackling health inequalities where people aren't getting the outcomes that others are. If we then move on to supporting our staff, to the next slide, Namu. What we have here, and there's Raj Jenna, who is the gentleman on the right-hand side in the middle, who is at the heart of our artificial intelligence in radiotherapy planning. So in terms of supporting our staff, we have a strategy that really has sort of 5 big themes. So resourcing is about making sure we've got enough people. Wellbeing is about supporting the well-being of our staff. Ambition is about making sure we're offering the very best opportunities for career development and training. And then relationships is about how we work with each other. But you'll see there in the bottom, in the middle, this piece around inclusion and ensuring we are enabling everybody in CUH to give of their best and to feel included and be able to move forward. If we can move on then to the, I think it must be the last slide around building for the future. So in terms of building for the future, Mike, you've talked about the integrated care system, our closer working with our partners, and I think you and I will miss our 3 years on the roller coaster of leading the STP and integrated care system. But we'll continue to work very closely with our partners on that agenda. The Children's and Cancer Hospital, hospitals are moving ahead at pace, and Mike Napton's leadership of that board subcommittee with other colleagues like Annette Doherty and Patrick Maxwell, I think is really helping those become a reality. And then I think there are other parts of our strategy that we're going to want to move forward around sustainability and the climate crisis, and also what we do in terms of the next journey of our digital strategy, which is being led by Sue Broster and Afzal Chowdhury, with again a lot of input from Adrian, which is to think, how do we move from being the most digitally mature hospital in the country to the most digitally mature campus and health and care system. So Mike, I think, and Julia, I think, you know, a really challenging year, but a year from which we've learned a great deal, and we're really trying to take that learning into the future. But as we all know, the absolute heart of this is listening to our patients, listening to our staff, and always reaching out to our partners. Mike, I'll hand back to you and to the next part of the session.
Thank you very much, Roland, and thank you to both of you, Julia and Roland, for that resume of activity, which gives a glimpse into what was a phenomenally challenging year, and which continues to be, as many of us know, because one area that perhaps hasn't come out too much so far, but it's implicit in everything that's been said, is that we were very much aware that COVID created huge problems for other patients. And that's created the delays and the backlogs and the extended waiting lists. And part of the challenge that no doubt in a year's time we'll be reflecting back on in next year's annual review will be what's going on today, which is how do we manage that cross current of continued COVID activity and presentation together with affected workforce across the whole of the health and care system, together with the anxieties of patients who've had their treatment deferred and worried about the security of their treatment going forward. And that's very clear, and I'm sure we will be coming back to all of those in a year's time. So I can see that there are some question and answer sessions, questions and answers on Zoom. So just to remind everybody, the facility is open to you to raise a question or make an observation. On Zoom, to use the virtual hand, to use the chat, or to use the Q&A function. So all of those are available to those of you who are looking in on Zoom, or on Facebook. Again, you can message in on Facebook and we'll pick up that question. So those are the ways in which your questions can be done. And I'm going to, and we did in advance have a question that came in from the Red Cross Lane Residents Association, which we will also come to. So let me start with the questions I can see so far that have come in online. So I've got a question from Facebook, which is, will the visiting at Addenbrooke's and the Rosie ever go back to normal? And of course, implicit in that have we changed everything forever? And will we ever go back to what we saw before as normal, or will we have a very adjusted normal? So I wonder whether, Ashley, could I come to you partly to explain why the visitor constraints that we have had were in place, and what motivates any continued restrictions, because clearly infection control is relevant to that. And if you want to answer the time as when will it ever go back to normal, please do. Otherwise, I'll pass that to Roland. But I think, Ashley, it might be useful for you to explain why the situation has been like this.
Yes, Mike, thanks very much. I mean, it's a really, really good question. as we know, the restrictions on the general population eased a little while ago, so that the compulsory wearing of face masks out in general society is no longer compulsory. However, we do know that we still don't have full vaccination across the UK, and we know that even those who are vaccinated can pass on coronavirus, and furthermore, there remain people who are vulnerable, even who are in hospital, who, because they don't have a fully functioning immune system, for example, or those who haven't been vaccinated themselves for some reason, or who are only partially vaccinated. So what we're doing is to maintaining social distancing and the wearing of face masks in hospital as much as possible. And one of the ways we do that is to reduce visiting. So across the organisation at the moment, there is some visiting in place for all patients. So, but that's limited. So what we don't see is multiple people around a bed all at the same time, to reduce the risk of people catching COVID. We also know, as part of that, as well as the immunocompromised, we know that people who've just had operations, for example, are particularly vulnerable to the effects of COVID. So I think this is a way of keeping our patients safe while they're in hospital, and to reduce infection. We do know that across the east of England over the past year, we've seen quite a lot, and across the country there were quite a lot of hospital-acquired infections, and Cambridge has done relatively well in that, and the data would suggest we've had one of the best outcomes across the east of England with the policies we've had in place. And so I think it's right to be cautious as we steadily lift those restrictions. The restrictions are largely lifted in maternity and paediatrics, but we're going steady on that. I don't think there's any particular desire for us to rush and to expose our patients to any more harm than they absolutely need to. As to when it will fully get back to normal, I think that's sort of how long is a piece of string. What I would envisage over the next few months is that we will continue to keep under review the rates in the community, the vaccination rates, and to risk assess the balance between the mental health issues and the benefits of having visitors versus the risks of crowding and large numbers of people coming into the wards. So I think it will be a slow and steady opening, is my prediction, but I wouldn't like to give you a time frame, Mike.
Thanks, Ashley. That's very helpful. If I can just illustrate a story about this, which is kind of germane to it. The fact that we were not allowing friends and family and visitors into the hospital was one of the many factors that was quite unsettling for many of our staff. And to give an illustration of that, I know, for example, in intensive care nurses, Roland showed Jane, who's our matron for intensive care. If I talk to the intensive care nurses, that's one of the things they really noticed, because normally if you had a patient in intensive care, very often the patient who was unconscious, the only way that you knew about this patient and knew what mattered to them was talking to the friend and family and having a sense that the friend and family were there holding a patient's hand. That was all denied through this COVID process. And that put a lot of responsibility on to intensive care nurses who, first of all, didn't have that sort of bandwidth and didn't have that connection with the patient in the same way that they ordinarily were done. And secondly, they themselves, as the intensive care nurses, had to act as the conduit to the family, who didn't know, other than what they were told on the phone, about how their father or mother or brother or sister or daughter, whatever, was doing. So that put a huge pressure on our own staff. And I think very much in terms of nursing, friends, family, relatives are partners in the care for a patient. So this isn't something that we do lightly. this is something that really has very profound consequences that we are very much aware of. Okay, thanks, Ashley. That was really helpful. Sure. There's a question from Val, which was Val Moore, who has been with Health Watch, and good evening, Val, which was, how are you working to understand how patients are doing and feeling who are on the long waiting lists? I wonder whether, Sue, could I come to you? I mean, just as I'm your Director of Transformation Innovation, but you were in the Medical Director's Office before that, and you will have a sense about how we do that. Just before I come to you on that, I mean, Julia will know that she and I were involved in a conversation a few weeks ago about the need to make sure that we are systematically trying to understand the impact of delay and deferral on anxiety and on the ongoing consideration of support to patients who are otherwise treatment being deferred. But Sue, do you want to expand a bit on that?
Yeah, thank you, Mike. So I think it's, fair to say in my medical career, so, I work as a doctor as well as in this role, I don't think I've ever seen waiting lists the length they are now. And I think that's something that concerns us all, that patients are waiting an exceptionally long time and what that means for them. I think there has been a real intention to communicate with patients on the waiting list, both by letter, on a relatively regular basis, through PALS with contact details about how we can get in touch and support them. And for those with some of the longest waits, directly from clinicians to really understand the impact of that. I think there is a process in place now within the Trust to really look at the long waits, particularly those for operations. And the patients who have really life-threatening illnesses or potentially life-limiting, they remain prioritised, and that continues. And the surgeons and the theatres are working at full strength. It's the patients who have really impactful long-term conditions who might be waiting a significant length of time that we know that can be waiting really huge amounts of time compared to previously, and understanding what that means for them becomes really important. So trying to work with the clinical teams who really understand their patients, know their patients well, to understand what that impact is, and help us make an assessment with their clinical teams and with GPs and our system partners about whether we need to reprioritise, reorganise where they are on that waiting list to try and treat them differently, treat them earlier, and think about different interventions to support them. So that remains something that has become something that we didn't have to do before, but actually something that we've put in place now to really build on that, and working very closely with our system partners to do that. It really remains a priority for us to try and work to reduce the waiting list as quickly as possible. So not just looking at what we can do here in this trust, but how we can work more widely across the system. So is there capacity elsewhere that we can use, and vice versa here for different specialties, different ways of treating people, and where we can use virtual technology, which isn't a caveat for doing some of this face to face, and certainly isn't a replacement for an operation, but can allow patients to have contact with their clinicians through either virtual consultations, building the capacity in MyChart, which is linked to patient records, to see if we can connect more regularly with patients. Absolutely, though, what I'd say is if you think there's more we could do, if there's things that we're not yet doing, if the things that you're being done really well elsewhere that we aren't, then we'd be really keen to look at that, because it remains a real priority for us.
Thanks, Sue. Thank you. That's really helpful. I'll just pass on a comment that Frankie has given, which was more, I'll read it out, more an acknowledgement than a question, to thank the end-of-life care team, the mortuary team, the chaplain's office and the medical examiner's office for the amazing job they have done and continue to do, especially during the very challenging early part of the year. Thank you. Thank you, Frankie, for making that point, because you're absolutely right. We had an end-of-life steering group meeting this morning, and the chaplaincy, hugely supportive. Alistair and Mark Stobart, who's just left, huge contribution to the hospital, but in particular the element of that contribution to end-of-life care, really strong. So thank you, Frankie, for acknowledging that. Could I just come on? We've got this theme of questions in regard to patients. I know there's a question there about staff. I'll come on to that in a second. But before I come to that one, can I come to one which again I'll read out, which is, apart from listening to staff and patients, are carers and family being listened to, especially for patients who are not able to respond, for example, dementia and disabled patients who are unable to speak for themselves. Ashley, just in regard to, can you remind me on that, you talked earlier about the visitors policy. Obviously there were very distinct groups of patients for whom not having a relative there was a particular challenge, and dementia patients would be one such. Any comments you want to make on that particular aspect about how we're looking after patients who aren't able to speak for themselves, and yet haven't got their friend or relative or carer to do that for them?
Yeah, I mean, very difficult one. It's obviously it's a very difficult time for everybody at that time, Mike. What we've tried to do is to ensure that those with carers passports are able to come into the organisation, so that we're able to get that support. And so that's one of our groups that we have prioritised for visiting as we've reopened, so that we really can get those people and allow carers in to be able to advocate for their friends, their relatives in the organisation. And we've tried to ensure that that's been a priority for the organisation, and to facilitate the virtual communications wherever possible as well. But the carers passport and bringing people into the hospital as soon as possible has been the key to that. We also obviously have safeguarding teams across the organisation for both adults and children who can advocate for those people, and who can ensure that the correct levels of care and the correct processes are followed, and that we don't make assumptions about what care someone might need or would want, and we try to find out from friends and relatives exactly what someone would want and need before we just make assumptions across the wards. But it has been a very difficult time. I think it's worth acknowledging.
Okay, thank you, Ashley. That's very, very helpful. So thank you. So let's come on then to a question that relates to staff, and then there's another question that relates to facilities in terms of the food court. But well, actually, no, I'll come to the food court first, because I kind of sense it's continuing the theme of supporting of families and carers and visitors. So the question is, when will the food court be open to the public again? David, do you want to just explain again? I mean, there were the particular reasons why the food court was closed, partly because of the fact that we were constraining numbers of visitors into the hospital, but it continues to be closed now for quite a pressing issue, which is one of our worries about the ability to do the right thing by our staff. But we do recognise clearly the impact of this for food provision to others. So do you want to just give a sense of the question of how the thinking about the food court has gone, and when it might be open to the public again?
Thanks, Mike. It's hard to just how far we go back in the story here, but essentially everyone will know we are an incredibly busy hospital and not blessed with space which is proportionately grown at the same rate as patient and staff numbers. So one of space, and particularly breakout space to get away from clinical areas, have a meal at some point during, for many of our staff, a 12-hour shift is a really important aspect of trying to keep our staff well and able to do their very, very best. So early in the pandemic, of course, as things closed down, generally, decisions were made about visiting and also space for facilities for patients and facilities for staff. So the various facilities in the organisation closed to the wider population and were retained as areas for staff. Now that's continued. Social distancing, the need to continue to keep safe environments in clinical areas and to allow people to get time away from those areas has been an important part of our work, our recovery work. Right now we maintain it. but in the very near future, we can expect the food court to start welcoming back in patients and visitors. There may be a period of time, there will be a period of time we expect to retain the food court for staff break times in the middle of the day when it's particularly busy. Really, those of you who remember it from pre the pandemic, the lunchtime period was particularly busy with visitors. We will retain that as a staff area for lunchtime probably, but we hope in due course to be able to expand some of the staff spaces and allow visitors full access to all the areas fully as we did before the pandemic. But we're a little way away from that, and we do need to invest in additional staff space to make that a sustainable possibility. Is that explain the story, Mike? We want to get back to it. We're trying to keep safe and be respectful of all parties.
That's very helpful, David. And again, I know that, just as friends and visitors and relatives, our co-partners in the improving of the health of our patients, looking after them is important. We do know that, and we recognise that, and we want to do that. So thank you. So I'm going to, just before I come over onto the car parking for staff question, just to note that there was a comment from Oliver on Facebook that he spent his 78th birthday in a ward at Addenbrooke's and all the staff were so kind and considerate. So on behalf of the whole hospital, Oliver, a belatedly happy birthday on your 78th birthday. I'm glad that the ward was able to compensate in a sense for you having to spend your birthday in hospital. And June, really good to see that you've had, surgeons and the teams saved your life in 2015, as you say, and successfully treated you. So I hope that you continue to be well. I have got the question from the Red Cross Association, which I'll come to in a second. But before that, should we just come to the question from on car parking, which is, will staff receive reduced parking rates at CUH? So David, can I come back to you? I do apologise to members of the public. I should have explained. So Ashley is our medical director. So Ashley's been answering questions on infection control and the constraints around visiting. Sue is was one of the medical director team, but is currently leading our drive on transformation and innovation in the hospital. And David is our director of workforce. So David, do you want to just say a little bit on staff and the parking rates and parking policy for staff at CUH?
Great, thanks, Mike. So I'm delighted that we have very much a mixed economy of how people get to and from work, how staff get to and from work. So I'm overwhelmed by the wave of cyclists who come onto site every morning, the public transport infrastructure, and those people, of course, who drive and live quite some considerable way away. Right now, staff who are shift workers, when they work shifts, lates and earlies, they are able to drive onto site and use the on-site car parks. We'd love to be able to offer that opportunity to all staff, but of course the capacity doesn't permit. So shift workers have access to on-site car parks, as do a number of other staff groups, such as carers, for example, and obviously the staff who have a disability. In terms of charging, during the pandemic period, NHS staff can park for free in staff car parks. At some point that will end, and we will return to charging staff the reduced rate for parking on site. The new regime, when that returns, when charging returns, we won't charge for people who are working the night shift. So that will be a free car parking event, and we won't be charging for staff who have a disability, who have a blue badge. So it will come, staff charging will return. It will be a lesser rate than the public. We will try and work with our staff and staff partners to make that as appropriate and respectful as possible, but there will be charging that returns in due course for our staff who access our on-site car parks.
Thank you very much, David. That's helpful. I mean, I think this is probably the right point to come to the question that was pre-submitted, and my thanks to the Red Cross Association for it. Now, just for the benefit of colleagues or members of the public who are watching in who are not quite sure what the Red Cross Association, Red Cross is that residential area just immediately adjacent to the hospital, to its south, on the way out towards Baybram and the Gogmagogs. It's near the Bell School, with the language school, and residents in that area have suffered quite a bit from parking issues, where people on the campus have parked or deposited people or collected people into and out of the campus, and that has caused some quite significant challenges, or very significant challenges, for residents in that area. So shall I read the question out, and then perhaps I'll come over to Ian, who's our Director of Corporate Affairs, to respond to that. So the question from the Red Cross Areas of Residents Association was, what steps are the Trust taking to address the dangers created in the Red Cross areas comprising Red Cross Lane, Stansgate Avenue and Greenlands from cars illegally parking? This means waiting, idling, parking and driving onto pavements, all of which is illegal, and all parking, whether an individual is in the car or not. They inform locals in order to, as justification for their parking, to attend meetings, treatments, or to pick up staff. The unintended consequence from the NHS parking policy and misunderstanding of double yellow lines is making the streets feel unsafe. In light of more clinics opening and staff numbers increasing, alongside changes to eligibility for parking, reducing staff's ability to park on your site, what is the Trust doing to establish an effective strategy to establish safer streets in CB2, the adjoining area, which enables safe, active travel routes and obviously is better for residents who are adversely affected by the situation? Ian, can I hand over to you for that?
Yeah, thank you very much, Mike, and a huge thank you, Steve, for the question this evening. Mike, perhaps I can just really begin by reiterating some of the comments you made earlier on in the meeting about the importance which we place as a hospital and as a campus on the relationships we have with our neighbours and maintaining, you know, what we want to be a really sort of constructive and regular dialogue, because we really do recognise, you know, the impact that a hospital and a campus like this does have on the surrounding neighbourhood. So that's why we have sought to work very actively over the last 2 years with the Red Cross Lane Residents Association to try and address issues, as you said, that relate to parking, to smoking, and in some cases to littering. Last year, the local authority introduced double yellow lines in some of the streets that you've mentioned, Mike, with the support of the Trust, and you know, that has had, I think, a significant impact on some of the parking issues on those 3 roads. But we very much recognise that there are ongoing issues, and we are committed to working as a hospital with you, with local councillors, and with other partners to address these to the best of our ability. So just thought it might be helpful just to sort of for the wider sort of attendees to understand some of the things we've been doing. So we've installed signage at various points on the boundaries of our site, reminding our staff and contractors of the importance of respecting our neighbours. We issue regular messages through our all staff bulletins to our staff, reminding them about not to park in these areas or to smoke in residential areas. And we did a couple of years ago now install a smoking shelter on the boundary of the site to reduce any smoking in the residential streets adjoining the hospitals. We've also put messaging on our website and in the communications we send out to our patients, encouraging visitors and patients to use the on-site car parks when they're travelling to the hospital by car, and not to park in the surrounding streets. And I know, Mike, at the end of July, I think it was, you met with a representative of the Red Cross Lane Residents Association, and again we've extended an offer to continue to work with the association, but also with local council, local councillors, to continue to look for further steps we can take to address these issues. And I just want to say, Steve and other colleagues, that our offer remains very open, and we're happy to meet at any point to continue those discussions.
Thank you, Ian, and very much reinforce that point. We are very happy. We don't want to be bad neighbours, and we are, so we very much wish to continue the discussion with you. I don't think I do see any other questions so far raised through Facebook or Zoom. What I will just do is are there any other board members who've not yet been brought into the conversation, wish to add in any thoughts on some of the general themes that we've discussed already by way of responses to the questions? I'm conscious that all of the discussion so far has been from the executive members of the board. So, I mean, Shirley, any observations you want to make as the person who chairs our workforce committee as a non-executive director, your sense of, the workforce and staffing concerns that we are dealing with both historically over the last year and today?
Yeah, I think the first thing I just want to draw attention to is the support of the health and wellbeing team within the trust, supporting staff and the hospital during what's been a very challenging time, particularly in terms of being able to step up and run the vaccination programme that we've been running, but also being able to provide extra support in terms of mental health support for staff who have been very affected by their experience of working during the pandemic. The workload has been huge, and they have worked really well to provide that support to all the staff. So a real shout out to them, really. I think the other thing just to say is that Roland alluded to the fact that pre-pandemic we had staff vacancy rates, particularly in the nursing team, that were significantly lower than we had had in previous years. And the work that David and his team have done pre-pandemic in particular to build the apprenticeship programme, which gives a lot of staff the opportunity to sign up and do a nursing qualification, has been an outstanding piece of work that has been an exemplar across the NHS and is a really important part of building our own local pipeline in terms of supply of future nurses. But that is only the tip of a big iceberg in terms of our demand for nursing staff and other qualified staff as well. And obviously during the pandemic, we were very affected by our inability to use our normal contacts overseas to build our overseas pipeline. And I think it's really important to recognise that as soon as we were able, we've reinstituted those overseas recruitment processes and are working hard to bring in staff to meet the needs of the trust. And this will be particularly important as we grow capacity because extra capacity will need to be staffed. But I think, again, a real sort of applause for the workforce team who have done hugely well to manage that in very difficult circumstances.
Thanks, Shirley. Thank you. And could I should just say that Shirley is our Senior Independent Director, so she is plays a very distinctive role in the board, and unfortunately we will be saying goodbye to Shirley in a couple of months' time when her period of office ends. So just again, Shirley, thank you to you for all you have done. Can I pass over to Sharon and Mike, because again, some of the themes that have come up in the conversation so far are around things like the experience of patients, our knowledge of what patients are experiencing in the context of anxiety about non-treatment or deferral of treatment, and also implicitly questions around the safety of that, which Sharon chairs our quality committee, but has also played a role nationally as one of the SAGE advisors to government through the pandemic, and has a continuing role in terms of genome sequencing and the like, and understanding of the variations and evolution of viral presentation. And so while Sharon was, we agreed to Sharon being on secondment for us for that period, because clearly that was vitally important national contribution. Mike Napton stood in to chair the quality committee. So can I just hand over to Sharon and Mike, any observations you've got on some of the themes around patient experience and patient quality and safety? Sharon?
Thank you, Mike. Thank you for giving me the opportunity to speak this evening. And I think I would make 3 points really. One is that a lot of background work needs to continue to happen in a hospital despite the COVID-19 pandemic. And so the committee has heard a great deal over the last year or so on a business as usual. And what I mean by that is that we have heard about things like pharmacy audits, you know, how are we handling our medicines, our infection control annual report, how are we managing our infection control, health and safety, and maternity standards. And so there's a lot of background work that's continued to go on, business as usual, despite everything. And we've seen some really kind of great work done despite the pandemic. I think the second thing to say is that, again, despite the pandemic, we've seen areas where staff have recognised that there needs to be work to improve the quality of care. And we have seen special attention given to areas such as eating disorder care in adults and children, mental health services. So we've had deep dives on how we're managing to give care to people with mental health issues, and sepsis. So people who come in with bloodstream infection, are we picking those patients up quickly in casualty and giving them the right medicines? So we're continuing to improve standards of care during that time. But the third point I would make is that, you know, we know the hospital is under huge pressure at the moment and has been for the last year or so. And so the other thing we've been doing is monitoring very carefully any harm that can occur to patients. So we've looked very carefully for signals of harm. And there's a review, a careful review that's done of people on waiting lists, for example. So we look at the impact on people on waiting lists, waiting for operations or for any other treatment. And we look at metrics on things like, you know, the frequency of people falling in hospital. And so there's a lot of work that goes on despite the pressures, and that's been, you know, a tribute to the staff that have been working hard to ensure patient quality of care. And I'm sure that Mike, who's been a fantastic chair during my absence, will have further things to add.
Thanks, Sharon. Mike?
Yes, well, thank you, Sharon. I'd endorse everything you've said. Perhaps the only other additional point I'd like to make is that the quality of care, patient safety and patient experience doesn't solely depend on what Addenbrooke's does. The care is provided by our partners in community services, primary care, the Mental Health Trust, Cambridge and Peterborough Foundation Trust, Peterborough. And so one of the things we did during the pandemic was set up a monthly meeting of the non-executive leads who were concerned with patient safety, experience and quality. And attending those meetings was very helpful in terms of understanding the pressures that we were all facing and making sure that our response to them were compatible, complementary, and some of the themes that came out of that you've already heard, but eating disorders one, mental health, but also children and young people services, particularly learning disability and such like. So that was perhaps an additional assurance that we were really working together across the system to try and ensure safe and high quality care for all our patients. The last thing I would say is, which hasn't been raised, there are a number of patients who have not been referred as well. So we're not only seeing a long waiting list, but there is a concern that we are seeing patients who have either had delayed presentations or who have not yet come forward. And we're thinking hard about how that's going to impact on outcomes from cancer and cardiovascular disease and such like. I think
Thank you very much, Mike, and thank you both Sharon and Mike. And just in the same way as I said that Shirley, unfortunately, is coming to the end of her term shortly, Mike will be coming to the end of your term next spring, so slightly later. And Mike's been on the board for 9 years, but has had a much longer association with the Trust in various fora before that. And has brought great insight to the hospital from the perspective of his having been a GP and understanding wider population health issues, which is something that we think is a huge contribution and very important to the way we operate as a hospital. We are not an island, we cannot work in isolation, as I said at the beginning, and Mike's been a very important part of contribution to the way we think about that. So my thanks again to Mike for that. Adrian, it won't have taken much working out. I'm going to come to you as well. So Adrian is the director of Performance Committee, which is the committee, the chair rather of Performance Committee, which again is a non-executive director. And that's the committee that looks at things like the flows of patients through the hospital, things like waiting lists, and how we can manage that more effectively, not from a clinical point of view, not from a patient quality point of view, but just to make sure that people aren't having delays that are unnecessary, that patients are able to leave hospital effectively when they have to or when they can, so that we are able to bring patients in. And that's part of the challenges we've had in, for example, the recent well-publicised cases in A&E. So Adrian, any observations you've got on some of the points or the conversation we've had so far?
I mean, I think relatively briefly, Mike, I'll say two things. One, a lot of the ground's been covered by other speakers, particularly Roland in his introduction. I think two things I'd mention. One, in the short term, first of all, we're acutely aware of the challenges in the hospital and the extraordinary efforts that our staff are making to meet them, and also the impacts of patients of the current situation. So very much has been described. I think there's the shorter term focus of the committee is trying to understand, challenge, but also support the constant juggling that the executive is doing while looking at flow, how we can improve it, looking at how we can improve the position in ED, looking at the balance between non-elective and elective when there isn't a magic solution for all of this in the short term, all in the context clearly of COVID and fluctuating numbers, and conscious that that has got better and worse. And, there are still a number of scenarios that may happen over the next 3 to 6 months about how they may pan out, and trying to understand that and the decisions that the executive then have to make and the trade-offs they make, and understanding those and seeing the best job we can do. However, I would say that also we are working with the executive on looking at the longer term. Clearly, the objective must be to try and get back to pre-COVID levels of performance at some stage, to reduce the waiting lists and to improve the overall quality of the services. Hopefully COVID dies down. So we are beginning to work with the executive on how we can resource and plan for, say, as the government target by March 24 to try and get back to pre-COVID levels. In our case, the introduction of additional capacity, which has been talked on, the new 40-bed and 56-bed units are going to be absolutely crucial to understand the timing and configuration of those and the impact on the improvement they will have, and also to work with a hospital that's already an exemplar of digital technology to understand how increasing digitisation opportunities for efficiency and improvement in service will affect the hospital as it continues to be at the forefront of digitisation over the next 2 or 3 years. So this is balance between managing through the constraints and challenges in the short term, but also really working hard with the executive on possibly, the more optimistic, exciting longer term as we seek to get back to the performance levels that we all aspire to as soon as possible.
Thank you, Adrian. That's very helpful. And of course, you work very closely with Mike, who is our Chief Finance Officer and who joined us during. When did you join us, Mike? It must have been during pandemic period, or yes, it must have been.
Yeah, that's right, Mike. So it was November 2020.
Yeah. It seems you've been here much longer, but yeah. So, Mike, as CFO, obviously, ordinarily in this annual meeting, the accounts would have been a feature that we would have discussed. But any thoughts or comments you want to make on the financial difficulties or challenges that we face? Because historically, of course, that has been a challenge for us as a trust. So.
Yeah, absolutely, Mike. I might start just with a more general reflection. And it reflects the fact that I'm new to the organisation, joined in November 2020. And I'm from a profession where we're not typically that emotional as accountants, but it's hard not to feel emotional. I'm really proud to be part of this organisation. When I read some of the comments and when I hear you Roland, and others talk about what we've done over the last 12 to 18 months, and as Roland said, we've done lots of things right. There'll be things that we haven't got right. And I'm really excited about what Roland set out about our strategy for going forward, about building for the future, and just linking with the finance. An example of that, last financial year, we spent £90 million on our capital infrastructure. So that's on buildings, on equipment, on our digital infrastructure, and that is helping us build for the future. That is 3 times what we had spent in the previous year. And that's setting the groundwork now for what's to follow with children's and cancer hospital developments. But on your specific question around the financial position, COVID has affected so many things, and it's affected the financial performance of the trust over the last 18 months. And we're really grateful for the support we've had from government to provide additional funding to allow us to respond in the right way. That has meant that as an organisation, and with the hard work of all the teams across the trust, we were able to deliver a break-even financial position for the organisation for the 2021 financial year. And we haven't got the accounts today, so it's probably not right for me to go into all the detail, and I'm looking forward to coming back at the right point to share all of that. But the overarching message of being able to deliver a break-even position and to start that journey to a longer-term sustainable position, both in terms of our building for the future and our core financial position as well.
Thanks, Mike, and that's not to be sniffed at, so to speak. It's a huge effort collectively to have achieved that position and continue that, because we know that the financial challenges have been really quite profound for the last 6 years or so, and yet we've been absolutely clear that that should never be at the cost of quality on the safety of our patients. So thank you, Mike, for that. So my thanks to a couple of comments on Facebook just before we close, from Chrissy and from Kerry. It's much appreciated, your very positive conveying of thanks to people who helped you whilst you or family were in hospital. So thank you to both of you for those comments. That, as I say, the sense that people are appreciative and acknowledging of the hospital is hugely helpful to those who work in the hospital, particularly in very difficult and challenging times. There was a question about whether or not there is electric vehicle charging available within the hospital. I'm not quite sure whether that's someone who can't get any petrol or diesel today and wants to know whether, but in that context, yes, we do. And there are 10 points available inside the entrance to car park 2 for those of you who are visitors who are otherwise coming into the hospital. But yes, we do. And of course, actually, that whole point about electric charging and availability provision is something that we will need to continue to work on in the future. I don't think I see any other questions or comments, but for members of the public who've not yet commented, if you do wish to do so, please do on Facebook, and we will be more than happy to come back with answers at that point. So please do. Thank you to all of you from the board who have been contributing to tonight's discussion. It's been really helpful, I think, to have that general sweep as well as the detailed answers to the detailed questions. So thank you to everyone who's here tonight. I can see by the delights of the office architecture that Sue, Ashley and Ian are still in the hospital. I can recognise those delightful offices, and you've probably been there since 8 o'clock this morning at least. So, so thank you to all of you, and thank you to members of the public for your continued interest, your continued support, but your continued concern about the hospital. We know that we are here to serve you and your families and your friends, and that is what we're here for. And we want to do it well and continue to want to do it well. So my thanks to everybody. Have a good evening, what remains of it. Those of you watching live, or those who are watching and recording, I hope you things are going well. And thank you to you all. And I've just seen a comment from Jerry, and we look forward to welcoming you, Jerry, as the County Council representative on the Council of Governors over the coming months. So thank you to everybody. Have a good evening, or if you're watching it, as I say, in recording, hope your day is going well, and thanks for everyone. Bye.